Hello, this is Erythrocyte disease hematology tutorial presented by the SchrDbb with reference Color Atlas of Hematology by Harald Thelm. So here we're going to visualize erythrocyte diseases. So you need to know that what the first erythrocyte disease that is very common is what is called anemia. Anemia can be just defined as a low level of hemoglobin, which is characterized by lesser than 13 gram per deciliter in males and lesser than 12 gram per deciliter in females adults. So that is what is anemia. Now, for you to characterize this anemia, you need to know that yes, there are certain terms that are going to be used, and is it clear? And these terms which are being used to characterize anemia depends on what is called the mean corpuscular volume, and also depends on the mean corpuscular hemoglobin. The mean corpuscular volume is actually the volume of hemoglobin, which is called the hemoglobin volume, which is contained in 1 red blood cell. Is it clear? That is the mean corpuscular volume. Now, the next one is the mean corpuscular hemoglobin. The mean corpuscular hemoglobin is the concentration of hemoglobin that is contained within 1 red blood cells. So that is actually the definition. Now, how do we calculate the mean corpuscular volume? So the formula which is used now in calculating the mean corpuscular hemoglobin, not the volume. Formula which is used to calculate the mean corpuscular hemoglobin is equals to the hemoglobin concentration divided by the number of red blood cells. Is it clear? So you know that hemoglobin is mostly made up of red. So in order for you to know that concentration that is inside 1 red blood cell, you take the total concentration, which is made up by all the red blood cells, divided by the volume of the red blood cell, is going to give you the mean corpuscular hemoglobin level. Is it clear? And now this mean corpuscular hemoglobin level and this mean corpuscular volume level is going to help you now to give now certain characteristics to the anemia. So the first characteristic that's going to be given to the anemia is called hypochromic anemia. So what is hypochromic anemia? Hypochromic anemia is just considered when your mean corpuscular hemoglobin level is going to be less than, so when the mean corpuscular hemoglobin level is going to be less than 27 micrograms, then it's considered as hypochromic anemia. Now, hyperchromic anemia is when it's considered greater than, mean corpuscular hemoglobin level is greater than 32 micrograms per micrograms. Is it clear? Now, these are the different cases. Now, there's also other terms which are used to characterize anemia called microcytic and macrocytic anemia. Microcytic anemia is characterized when you have a mean corpuscular volume of less than 80 femtoliters, while macrocytic anemia is when it's characterized when you have a mean corpuscular hemoglobin level of greater than 100 femtoliters. So let's see here. We have actually this hypochromic. So there you have an iron deficiency anemia. Iron deficiency anemia is an example of hypochromic anemia. Is it clear? So now let's visualize now this point. Now you need to know that what? You need to know that with iron deficiency anemia, we actually have a deficiency of anemia, and this is a table that's going to help you to understand what can make you a deficiency in iron. The first thing can be insufficient absorption of iron. You need to know that what there are certain cases where you can have insufficient absorption of iron, like in the cases of lower than normal activity, no activity, or stomach resection. So if you have all these cases, you can have reduced absorption of iron. The next, we have substances that inhibit the absorption of iron, like citric acid. Lactic acid can inhibit the absorption of iron. Now the next one is also substances that facilitate iron absorption, like vitamin C is missing. So vitamin C is very important in order for you to absorb iron 3 iron. Now the next thing is insufficient iron supplementation. Is it clear? So if the patient also has decreased iron supplementation, is going to, like iron deficiency diet or in units where there is insufficient iron at the level of the breast milk, we are going to have iron deficiency anemia. The next one, we have endogenous redistribution. Is it clear? You have endogenous redistribution. So endogenous redistribution, like in the case of tumors, infections in lung, and hemosiderosis, can cause the iron. Is it clear? Particularly infection, because infection uses the iron in the body in order to spread. Is it clear? Now we have another one, which is chronic bleeding. But sometimes you need to know that when you have a very chronic infection, the iron may be deficient, not because the patient is actually deficient in iron. The patient may have normal iron, but he has a form of iron deficiency anemia. Is it clear? I hope you're understanding. So you have a deficiency anemia, which is due to a chronic infection, but actually the patient has iron. Why? Because the iron is being stored inside the ferritin of the patient. Now the next thing, you have chronic bleeding also. If you continuously bleed, you're going to lose your red blood cells and then iron, like disorder of the stomach, diseases of the ureter, like hematuria, like disease of the female reproductive tract, like menorrhagia, metrorrhagia. Now we also have increased iron requirements like growth and maturation, increased production of new red blood cells, like in the case of a sickle cell patient. The next thing, we have physiologic iron loss in females, like menses, lactation, and pregnancy. So all this is going to result to iron deficiency. And iron deficiency, how does it present? Present with fatigue. It present with chorionesia. So chorionesia is actually that you have a spooning of your nails. Is it clear? So you have chorionesia, you have infectious angle, so we have angular stomatitis also. It means that when you have striations at the level of the angle of the lips, you have angular stomatitis. You can have a Plummer-Vinson syndrome, and Plummer-Vinson syndrome, you have many ulceration at the level of the lips and at the level of the oral mucosa. It's also associated with iron deficiency anemia. You have also we also have an iron deficiency fever. Now the next one, you can also present with anemia. You can present with hypochromy and ring shaped erythrocyte. So we have hypochromia on the full blood on the microscopy, and ring shaped erythrocyte. The next one, we have light serum deficiency in color component. Is it clear? So you also need to do serum iron. You have total iron binding capacity, and we also have ferritin. These are the three main workup that I use when you have a patient that you suspect that it's an iron deficiency anemia. So those are the three main cases. In case of the serum iron is going to help you to know the level of iron that is going to be inside the blood, and the serum iron is what is helping you to say that there is actually an iron deficiency if the value is less than normal. The second is the total iron binding. The second is the ferritin level. Ferritin, if the ferritin is high, it means that what the patient may have low iron in blood, but the patient is storing his irons. Is it clear? So it's an iron deficiency anemia that does not require to be treated with iron. Is it clear? And the next one also, you can have also a case of total iron binding capacity. Is it clear? Normally, when we are breaking down red blood cells, or when there is loss of iron, the total iron binding capacity is going to increase, such as to transport more of the iron from the gastrointestinal tract into the blood. Is it clear? But in case where you have excess ferritin already in the body, is it clear? The body is not going to try to transport more iron from the gut into the blood. Yeah, that's why the total iron binding capacity, that's the transferring level, is going to be very low. So this is a diagnostic finding and the workup of important disorder of red cell series. So I'm not going to speak about that. So you can pause in order to visualize the different elements. So this is it. You can pause to visualize the different elements. Okay, now we need to know that this is actually a patient now with iron deficiency anemia. Is it clear? So iron deficiency anemia, diagram A and diagram B. You see this is A, so you have erythrocyte morphology with iron deficiency. You see actually here you see this hypochromia. The normal red blood cell is supposed to be reddish. It's supposed to be more like this. It's like a normal red blood cell. Now we need to know that one normally red blood cell exists in a biconcave is biconcave. Is it clear? So since a red blood cell is biconcave, is a biconcave dish, it means that what the central portion of red blood cell is going to be as reduced than the peripheral portion. That is why this space here is normally whitish on the red blood cell. Now in hypochromic anemia, which can be caused by iron deficiency anemia, we realize that what the central portion increases in size. Is it clear? That whitish portion increases in size, so it's telling you that there is hypochromia. Is it clear? So in diagram 2, so those are the diagram. So the next one, we have diagram 3. You can also see a lymphocyte here at this portion here. So you can see the diagram C is a diagram of the bone marrow. So in the bone marrow, you see that what in iron deficiency anemia show only increased hematopoiesis and left shaking basophilic erythroblast. Is it clear? So you are going to have in iron deficiency anemia, you are going to have more production of basophilic erythroblast. We have also absence of iron deposit after iron staining. So you can also do a Prussian blue reaction. You are not going to see iron inside with iron staining. You can also have Prussian blue, Crazin blue, which can help you to identify. Prussian blue particularly help you to identify iron. Is it clear? So those are the different things. Now also, so these are the case where you can have an iron deficiency anemia, and this now is a diagram which to show the different blood cells. Now hypochromic anemia. So this is hypochromic anemia now due to an infectious origin. Is it clear? So now we need to know that what hypochromic, in contrast to exogenous iron deficiency anemia, the following phenomena are often observed when you have a hypochromic anemia which is due to infectious origin, secondary to an infectious cause. So those are the different characteristics in contrary to in case of hypochromic anemia due to iron deficiency anemia. Here you can have anisococytosis. Anisococytosis is a strong variation in the size of the erythrocytes, so beyond the normal distribution. So you have a strong variation in the size of the erythrocyte beyond the normal distribution. So you are going to have the result is that it's in almost every field view, some erythrocytes are either half the size or twice the size, or so you see the size is anisococyte. Anisocytosis, it means that the size is varying much more than the normal standard variation of the red blood cells. Now we have also what is called poikilocytosis. It's a variation in shape of the erythrocyte other than the normal variation of shape. So in this variation of shape, you can have normal round shape, you can have oval shape, you can have pitch shape, you can have teardrop shape, you can have all these shapes are seen. Now we also have polychromophilia. Polychromophilia is also seen in cases of a toxic anemia or an infectious anemia. We can have polychromophilia. So it is the third phenomenon is actually a series of non-specific indicators disturbed by erythrocyte maturation. So refer to light gray blue staining of the erythrocyte indicating severely damaged hemoglobin content of the immature cells. Is it clear? So in this case, since you have anemia of infectious origin, so in this case now it means that what? It means that there is not enough iron for the production of erythrocytes which are being destroyed because of hemolysis caused by the infection, and because also the infection requires the iron to grow. So your body is going to compensate the mechanism in such a way that what you are going to store more of your iron so that no iron is present in the blood for the bacteria or the pathogen to proliferate. Is it clear? Now when the body tries to compensate, that means mechanism for the bacteria not to proliferate, what happens is that what the bone marrow is not going to have enough iron now for the production now of the red blood cells. So when the red blood cells are being destroyed by hemolysis caused by the infection, the red blood cells which are now produced are malformed, and they have also polychromatophilia. Is it clear? And this polychromatophilia means that what they have different colors. So some red blood cells can be bluish, some other are reddish, some other are white. So those are different color. Now we have basophilic cytoplasmic shaping of the erythrocyte is a sign of irregular regeneration. So normally we say that when you have also an iron deficiency, you're going to have more of basophilic erythroblasts. Is it clear? So it means that normally hemoglobin is supposed to be reddish when it is produced at the end of hematopoiesis, but in this case you are not going to have enough hemoglobin inside the red blood cell. So the patient, the red blood cell is going to remain basophilic as it was in the erythroblast form. So those are the different cases that you see in an infectious. So this is now a diagram showing a secondary anemia, and anemia which is due to of another cause, like in infectious cause, in toxic anemia. So now this is a teardrop cell, as you can see here. Diagram 1 is a teardrop cell, as you can see. Now so you have a teardrop cell. So you see in this diagram here, we see multiple shape of the red blood cell. You see teardrop here, you see oval here. So those are the multiple shape, and this can so multiple sizes. Sorry, so this is big, this is small, this is big. So you have multiple sizes. So it shows you that there is anisococytosis for multiple sizes. Now the second one is multiple shape also. This is a teardrop cell here that you can visualize. Is it clear? You have number 2, you can see a ball cell. This is a ball cell here. So number 3, sorry, is a ball cell. This is a ball cell. This is a teardrop cell. Number 1. Number two is basophilic shaping. See how it is bluish inside, and this number 3 is a ball cell. Is it clear? So those are the different things that you can visualize. So this difference in shape here can show you that there is poikilocytosis. Is it clear? Now the next image now is the bone marrow. So how does the bone marrow resemble in this case? So you say that, so in this case, bone marrow, the cell overview in secondary anemia, the cell count is in the white cell series are elevated. So you see, so you have more white blood cells than the red blood cells in the normal bone marrow spectrum. Normally the red blood cell and white blood cell have a certain proportion, but when you realize, you see that there are more white blood cells than the red blood cells in the spectrum of the bone marrow. Is it clear? So now we have bone marrow cytology for diagnosis of hypochromic anemia. So you can visualize it. You can also do hypochromic anemia. So we have also hypochromic anemia with sideroacrasic anemia. So you can have also sideroblastic anemia, which can result to hypochromic anemia. And what is idiopathic anemia? Sideroblastic anemia is a form of an anemia with hemosiderosis. Is it clear? So it means that what? It means that the iron that is inside the blood is only going to be stored in the different part of the body, and is going to be absent at the level of the blood and at the level of the bone marrow. So that's why it's called sideroblastic anemia. And also you have the formation of the sideroblast. Is it clear? In sideroblastic anemia. So in sideroblastic anemia, the anemia existing iron cannot be utilized. Is it clear? There is iron which cannot be utilized. So what the word now is acrastic anemia, means useless. This is a suspected diagnosis when the serum iron level is raised or is normal, but and when the erythrocyte show a strong anisococytosis, poikilocytosis, and you also have polychromatophilia. So you have all the same thing like a toxic anemia. So it's a secondary anemia due to something, but in this case the iron cannot be utilized by the body. Is it clear? So that's sideroacrastic anemia or sideroblastic anemia. So how do sideroblastic anemia actually present? They present with normochromic or hyperchromic. Is it clear? Why in iron deficiency anemia? So in this patient, they have normal or high iron. Is it clear? But the way they use iron is not normal. So you are going to have a hyperchromic or a normochromic anemia. Is it clear? And you also have anisococytosis. While in the case of a toxic anemia, you have a hypochromic anemia with all those features: anisococytosis, poikilocytosis, and also polychromatophilia with basophilia. So now this is hypochromic anemia due to hemolysis. One consists of thalassemia, and thalassemia is an autosomal recessive disorder. Is it clear? An autosomal recessive disorder which can exist in two forms: alpha thalassemia and beta thalassemia. Is it clear? Now, beta thalassemia, you only have two genes, two alleles which are involved in beta thalassemia. Is it clear? While alpha thalassemia, there are 4 alleles which are involved in alpha thalassemia. And in alpha thalassemia, they can exist either in a cis or a trans form. The cis form of the alpha thalassemia is going to be more pathologic than the trans form. And when you have a homozygous pair of the cis form of the alpha and beta thalassemia, it means that you're going to suffer strongly from the disease. Now, this is a case of a thalassemia. You see, actually in thalassemia minor, so when you have a thalassemia minor, actually is when you have only one trait of the disease. Is it clear? But you are not a homozygous pair, you are a heterozygous pair. That's the thalassemia minor. While thalassemia major is when you are a homozygous pair of the alleles of the disease. Now let's come back here. So if you have a thalassemia, so in diagram A, every patient having a thalassemia minor, so often no target cells. So you have no target cell is seen, but there is an increased number of small erythrocytes. You can see small erythrocyte here shown in the diagram. Small erythrocytes shown in the diagram with a lymphocyte. So this is a particular lymphocyte here. In diagram B, we have more advanced thalassemia minor. So this is a more advanced. So you see here in thalassemia minor, normally there is no change in the shape. There's only hypochromia, and there is normal size. The size is small, but there is no change in size. And in case of when the thalassemia is now advanced, is it clear? Thalassemia minor is now advanced. You have both anisococytosis and you have poikilocytosis. Is it clear? So here you have no anisococytosis, no poikilocytosis. You only have hypochromia. But when it is slightly advanced, you have both anisococytosis and you have poikilocytosis. Is it clear? So this so you have also a basophilic stripping. Say basophilic stripping means that there is basophilia. Is it clear? Now we have in diagram 2, we have what is called some target cells can be seen. So sporadic target cells. Now in thalassemia major now is seen in this diagram here. Thalassemia major is seen in this diagram means we have a homozygous pair of the pathological allele. So in thalassemia major, what do you have? You have erythroblasts. Is it clear? You can visualize diagram 1. You can see erythroblasts in blood. Is it clear? In thalassemia, so you can visualize erythroblasts in blood. You can visualize target cells. Is it clear? So the 2 are the target cells. So when things like just like this, you have target cells. Those are thalassemia major. You can visualize it. In thalassemia major still, you can see polychromatophilic cells. So diagram 1, sorry. So in diagram 3 are polychromatophilic cells. That is polychromatophilic cells. Now diagram 4 is going to show Haematology bodies. So when you have these bodies inside the cell, inside the red blood cell, normally when the spleen is functional, you have the Haematology bodies. Any cell that have Haematology bodies and any cell that have any cell that is malformed are supposed to be removed. Is it clear? But now in case of thalassemia and hemoglobinemias, the spleen is having a function. They actually are having a functional asplenia, meaning that what their spleen is no more functioning. Since the spleen is no more functioning, that's why you have different sizes of cells which are malformed, red blood cells which are malformed, red blood cells which have different sizes, red blood cells which have bodies inside them, like the target cells, like the Haematology bodies. All these type of cells are not supposed to be present. So it's because of the functional asplenia that you have all these pathologies. Is it clear? You can also see lymphocytes in diagram 5, and you can see granulocytes in diagram 6. Now you have also normochromic anemia. Is it clear? So in normochromic anemia, so you need to know that what there are different causes in normochromic anemia. What is your MCH is going to be normal, but you have a low hemoglobin level. It means that what your MCH is going to lie between 27 and 32 picograms. Is it clear? That's normochromic anemia. Now, from normochromic anemia, the causes of normochromic anemia, there can be different causes, but the major cause of normochromic anemia, you can have hemolytic anemia, so due to breakdown. You see, so when you have a hemolytic anemia, it can cause a normochromic anemia. Now let's visualize normochromic anemia. So example of a hemolytic anemia is in our context Cameroon, where you can have a patient that has malaria. Is it clear? So a patient that has malaria is an infectious disease that is directly going to break down the cells. Is it clear? So it does not, so malaria does not actually is not going to cause, is not going to use iron. That is why the body is not going to store the iron. Is it clear? So actually these patients who have malaria do not store iron in themselves. The red blood cells only the malaria, the plasmodium parasite only break down the red blood cells, but without using iron. Is it clear? Since they are not using iron, the body is not going to store the iron for you to have an iron deficiency anemia. Is it clear? So in patients that have anemia with malaria, it's supposed to be a normochromic anemia. You see, their hemoglobin level has to be low, but their mean corpuscular hemoglobin has to be normal. Is it clear? So now in this case of normocytic or with normochromic anemia, so you think of hemolytic anemia like malaria. So now let's come in examples here. So you see here a peculiar characteristic of hemolytic anemia we are going to show on this diagram. So the first diagram A, in diagram A actually you see diagram A, actually you are going to see the red blood cells. The red blood cells are going to be normochromic. Is it clear? Now we need to know that there is another diagram. You need to know that there is a peculiar characteristic of hemolytic anemia. When there is hemolysis, the more there is hemolysis, the more there is going to be a left shift from the bone marrow, such that the bone marrow is going to replace the red blood cells that are being lost. The more there is hemolysis. Are you understanding? The more there is hemolysis, the more the bone marrow is going to replace the red blood cells that are being lost. So you're going to see a high level of reticulocytes in blood. Is it clear? So diagram 3 here. So diagram 1, you can see erythrocyte. This is an example of an erythrocyte. Is it clear? A polychromatic erythrocyte. Is it clear? Now after, so you have also, now you have the next stain here. So when you use now the stain here, this stain is called the Papa-Heim stain. Is it clear? This stain is called the Papa-Heim stain, or you can also use the crazy blue stain. Is it clear? So when you use this stain now, you are going to see that there are going to be nuclear bodies inside some nuclear bodies inside this red blood cell that has been produced. So is it clear? So that's why these nuclear bodies now are revealing that these cells are actually reticulocyte. Is it clear? When you use the normal hematoxylin erythrin stain or azu stain, you see that the red blood cells and the reticulocyte are not easily distinguishable on the microscope. You see that these cells here and these cells here are not distinguishable, but this is actually an reticulocyte, while this is a red blood cell. Is it clear? But when you use a crazy blue stain or you use a Pappenheim stain, and you are seeing that you are going to see some bodies inside, some nuclear bodies inside, because the reticulocyte have not yet lost all their nuclear material. So you are going to see some nuclear bodies inside the reticulocyte. So when you see many cells like that with nuclear bodies inside, with fragmented nuclear bodies inside, it may make you think of a hemolysis that has occurred. So like in the case of a hemolytic anemia with malaria. Is it clear? So this is now a bone marrow spectrum. So in the bone marrow, you see hemolytic anemia. So you have hemolytic anemia at low magnification. You have so it's going to show increased hematopoiesis. Is it clear? With cell cluster, you can see orthochromatic erythroblast predominate. So in this case, you are going to see a high level of orthochromatic erythroblast predominating, and the basophilic erythroblasts are going to be loosened, so they are going to have low level of other erythroblasts, high level of orthochromatic erythroblasts. While in the case of the other anemia that we saw, the like iron deficiency anemia, we said that the basophilic erythroblast was predominating the bone marrow, but here in the case of hemolytic anemia, is the orthochromatic erythroblast is going to dominate. Now, the next thing are the causes of the most common hemolytic anemia. So, what are the causes of the anemia? You can the cause of the most common hemolytic anemia. You can have the different causes. Is it clear? The first one, it can be hereditary or it can be acquired. So, this is the case of hemolytic anemia. The first one, hereditary. Hereditary can be one, a membrane abnormality. 2, it can be hemoglobin abnormality. 3, it can be an enzyme defect. And acquired in the case of paroxysmal nocturnal hemoglobinuria and ZF syndrome. So in membrane abnormality, we have spherocytosis, hereditary spherocytosis, we have hereditary erythrocytosis. In hemoglobin abnormalities, we have thalassemias, we have sickle cell anemias, we have other rare hemoglobin related disorders. You have enzyme defects like glucose 6-phosphate dehydrogenase deficiency, you have pyruvate kinase deficiency. Is it clear? And in acquired, as I've just said, you have paroxysmal nocturnal hemoglobinuria, you have ZF syndrome. Now, what are the causes now of the extra? Because this one is intracorporeal, so it's it's inside due to the host himself. Why this one now is because of the external abuse. So external factors. So we have things like bowel synthesis of our antibodies, which is due to an autoimmune reaction due to erythroblastosis and transfusion. Because of transfusion, when there is erythroblastosis fetalis, like in the case of erythroblastosis fetalis, or there is transfusion of an incorrect blood, it can cause that. If there is warm autoantibodies, can cause that. If there are cold autoantibodies, it can cause that. Now we have chemicals. So chemicals like cephalosporins can also cause an autoimmune antibodies to your cell. Now physical or chemical things that can cause also hemolysis. You have burns can cause hemolysis. Heart valve replacement can cause hemolysis because the red blood cells are going to pass through the valve and the valve is going to break down those red blood cells. You have heavy metal exposure. You have microangiopathic hemolysis. A microangiopathic hemolysis is a hemolysis that occurs when red blood cells are going to flow through a small blood vessel. So when they flow through a small blood vessel, they directly collide and they break up. Microangiopathic hemolysis. We have infection-related nausea. Is it clear? Like in cases of influenza, you have salmonella, you have infections like malaria in our context, Cameroon. The next one, we have hypersplenism. So hypersplenism, when there is excessive activity of the spleen. Is it clear? So it's going to excessively break down. So those are the different causes of hemolysis that you can have in mind. Now, in this case, now we have auto-agglutination and fragmentocytes. Is it clear? So in this case, A is going to show clumps of red blood cells. So when you see clumps of red blood cells, you can think of autoantibodies. Is it clear? So it's an artifact of serogenic things. So now the diagram, so they can also see thrombocytes, many thrombocytes at this level here. But when you see already the red blood cells which are coagulated like that, it means that they are autoantibodies. Now the next one is that you have the next is diagram B and C. So it's you see conspicuous half moon appearance, and you also have an eggshell half moon appearance. Also have an eggshell shape red blood cells. So this is the half moon appearance of the red blood cell. We also have an eggshell shape appearance of the red blood cells. Is it clear? So we also have fragmentocytosis, and all this. So when you have half moon appearance of red blood cell, eggshell shape of red blood cells, all the fragmentations of red blood cells, you can think of a microangiopathic hemolytic anemia. So all these cells are called fragmentocytes. So like in diagram 1, you have a half moon appearance like that. This half moon appearance is going to be called the half moon appearance of the red blood cells. Is it clear? Is going to be called fragmentocyte. The next one you have also target cell. Target cell is shown in diagram 2 here. So you have target cells here, and number 3 you have echinocytes. Is it clear? Echinocyte is shown in diagram 3. Is it clear? So this is but it has no diagnostic relevance, the echinocyte. Now we have cytomorphologic anemia with erythrocyte abnormalities. So this is this anemia. Now you have this anemia which is due to a different, you are going to have different morphology of the red blood cells. Is it clear? So the different anemia where you have more different changes, the anemia with change in morphology of red blood cells. We have microspherocytosis. Is it clear? This is a corpuscular form of hemolysis and is characterized by dominant genetic transmission, splenomegaly, and long uneventful course of occasional hemolysis crisis. Microspherocytosis. You have a morphological change in the red blood cells. So red blood cells are going to resemble a particular shape. You have stomatocytosis. So stomatocytosis is an extremely rare hereditary condition. The stomatocytes are red cells with a median streak of pollen given as cells of fish mouth appearance. Is it clear? So they have a fish mouth appearance, these stomatocytes. When the red blood cells usually have fish mouth appearance, you think of stomatocytosis. The next one, you have hemoglobinopathy. So in hemoglobinopathy, you have target cells are frequently present in hemoglobinopathies. Is it clear? Now, target cells are present in the case of beta thalassemia. You need to know that alpha thalassemia, or target cells can also be present in sickle cell anemia. Is it clear? But usually what you're going to see in sickle cell anemia are sickle cells, not target cells. Now the next one, so this is in hemoglobinopathy. Now another thing that can cause also anemia with malformed red blood cell is schistocytosis, and schistocytosis are also fragmentocytosis. But we also said that what the fragmentocytes can also be present at the level of in case of a microangiopathic hemolytic anemia. So in this case, if you have an acquired hemolytic anemia, some of the erythrocytes are fragmented. Is it clear? And the various irregular shape, like you're going to have eggshell shape, you have helmet shell cell shape, you have triangular cell shape, you have crescent shell shape, like the lunar appearance. It may make you think of this disease. But this, you need to know that what usually schistocytosis or fragmentocytosis is associated with a microangiopathy, a disorder with a rigid blood vessel which make the red blood cell to collide with the wall. So it's usually associated with a microangiopathic hemolytic anemia or a disseminated intravascular coagulopathy. Is it clear? So you are going, when you develop now a cause of thrombocytopenic purpura, because normally you need to know that what when you have a microangiopathic hemolysis, what happens is that so you are going to have the colliding of the red blood cells, the colliding and the fragmentation of the red blood cells. Is it clear? So later on, when there is fragmentation of the red blood cells, you are going to have decrease in the thrombocyte, because the thrombocyte are going to try to coagulate those red blood cells, and this syndrome is going to be the Moshko-Witz disease. Is it clear? So those are the different things that is involved here. So this is the diagram involving microspherocytes and all the like. So microspherocyte and all this, and from here we are finished with the first part of erythrocyte disease. We say thanks for your kind attention. Don't forget to like and subscribe for our channel. Thanks very much.